And so endocrine is going to be about diabetes, about 90% of the time, right? And that's in real life too. 90% of your endocrine disorders are diabetes and diabetes mellitus, because there is such thing as DI and SI, right? And that's to do with like ADH stuff. That's probably third place. One of the most common after diabetes would be like thyroid stuff, all right? So TSH, T3, T4, those kind of things, right? So thyroid disorders are like the other like 9%, and then you got some ADH stuff, whether it be DI or SI. And then you start talking about like steroids, and you start talking about like pituitary stuff, right? So we're going to get into those things, and we'll spend a little more time on diabetes. But these are the kind of where endocrine lies, and endocrine is a little better than hematology, in that there's actually the names of the hormones, the names of the things actually mean something. Except when you start getting to like thyroid stuff, they start messing it up over in thyroid, right? So probably got hematology involved over there, right? But otherwise, ADH makes perfect sense. Steroids make most sense. Makes sense, they're pretty straightforward. And the pituitary stuff has to do with everything else, right? Basically, the pituitary is in charge of ADH, in charge of TSH, in charge of steroids and ACTH, which stimulates steroid release. So, we talk about pituitary last because it's going to have all the symptoms of all the other things. Okay. So diabetes itself. So diabetes mellitus, right? So this is where you have increased sugar for some reason, right? Their most common reason would be someone who has metabolic syndrome, especially in America. That's where someone has like an apple shape. They have obesity. The BMI is high, right? The BP is elevated. Triglycerides, cholesterol is not where it should be. Waist circumference, again, it's apple shaped. They got wide, they got more than 40 inches on their belt for men. And also combining the sugar piece, right? So the sugar piece being that they have a sugar that's elevated, right? And usually it's over 126 is usually what defines diabetes. Then sometimes A1C is involved in here as well. And we'll talk about A1C briefly, where we talk about their control of diabetes or control of their sugar, at least for the last 3 months, right? So these are really modifiable. Metabolic syndrome is a modifiable thing in America. Right, we can fix dyslipidemia, we can fix the BMI, we can fix the blood pressure, we can fix the hyperglycemia, right? And otherwise, there's that's going to lead to type 2 diabetes, which we'll talk about. And there's such thing as type 1 diabetes, which is more genetic and more there's an autoimmune process. Okay, but diabetes is super popular, right? It's the seventh leading cause of death. Every 23 seconds, someone gets diabetes, is diagnosed with it. Every 10 seconds, someone dies of diabetes. And might not be the diabetes directly, but diabetes has a lot of complications, including heart disease. Number one reason for chronic kidney disease. Puts you at risk for strokes. It causes a lot of problems, a lot of sequelae, a lot of complications occur because of diabetes. So getting this A1C, the sugar controlled over the last 3 months, is kind of critical, and that's what we're going to look at to see that we can get there. How if someone's diabetes is under control, right? That's very popular worldwide. Younger people are getting diagnosed with it. It used to be type 2 diabetes was adult onset, but no more. In the last 15 years, it's been type 2 diabetes has been getting increasingly diagnosed earlier and earlier, right? Because more and more people are getting more and more metabolic syndrome. When they get the waist sizes, they get the BMI that is greater than for their age. Okay, so about 1 in 4 patients are going to be diabetic in the hospital setting. So it's important to recognize that so they don't get complications of low sugar or high sugar. And then also they can be admitted to the hospital because of a diabetic complication. In the ICU, that most commonly be DKA, right? And so DKA can develop from type 1 or type 2 diabetics. Usually type 1 diabetics initially present like a new onset diabetic. Is usually because of is a type 1 diabetic who's presented the complications of DKA. But hyperglycemia is hyperglycemia. So it has the same symptoms no matter how you spell it, right? It's going to be the 3 Ps that you always hear about, right? Polyphagia, polydipsia, and polyuria. So 3 Ps are for both type 1 and type 2. But type 1 usually presents with DKA symptoms, which we'll talk about. But we want to kind of tease it out just a little bit because they're not one and the same, right? Can type 2 diabetics get DKA? Yes. And what's the other complication that happens with hyperglycemia in diabetics besides DKA? HHS, right? It used to be called HINK, HHNK, or HONK, which I like a little better. But so HINK or HONK or HIS, right? So these ones are also complications of diabetes, and it's only a complication of type 2. It's impossible to get in type 1. Okay, so we'll talk a little bit more about the complications. We kind of talk about the causes. We'll talk about how diabetes kind of affects the body. upcoming, and then what the symptoms would be and what the complications of diabetes would be.
What do you get when you guzzle down sweets?
Type 2 adult onset diabetes.
All right, so the pathophys, and this is the pathophys of type 1 diabetes. The next slide will be type 2 diabetes. Type 1 is an immune attack. So we've got little antibodies, which you're familiar with from hematology. We're talking all about antibody response and our immune reaction. We got dosed with an antigen of some sort, and that antigen looks exactly like our beta cells of our pancreas, right? Beta cells of the pancreas are what release insulin. So we have something it could be a trigger in the environment. It could be something genetic. There's something that looks that made us form our own antibodies against ourselves, right? So drugs, toxins, being exposed to dairy at a young age, right? Stresses from, can make it happen. So these are things that will put us at risk for our beta cells dysfunctioning. The whole idea behind type 1 diabetes is that it's a deficiency of insulin. So there's not enough insulin being produced, right? So why is it not being produced? It's because the beta cells are being attacked by antibodies, for instance, right? You got little antibodies here attacking it. Okay, so make that three-dimensional there. It's an artist. All right, so you got an attack on these beta cells, therefore no insulin, right? Insulin is our only hormone, right? There's only one hormone in the body that lowers your blood sugar, right? And that is insulin. So if we don't have insulin, we have a deficiency of it, we are going to get hyperglycemic, right? So they're going to start getting the symptoms of hyperglycemia, the 3 Ps, right? Which we'll talk about in more detail and why that happens, right? So it's destruction of your beta cells, right? Is the most common reason, whether it be an autoimmune attack against our beta cells. It's not intended, it's just the exposure to these antigens made us produce antibodies, and those antibodies were then made and attacked our beta cells, right? In our pancreas. We talked about pancreatitis, right? Pancreatitis was when we have a inflammation of the exocrine function of the pancreas, right? Now we're talking all about the endocrine, right? The only difference between exo and endo is what? Where the secreted substance goes, right? If the secreted substance goes into the blood, it's called endocrine, right? If it goes and not in the blood, it's called exocrine, right? Not blood, I guess we could say, right? So like sweat is not an endocrine process, it's an exocrine process. Secretion of amylase is an exocrine process, right? Secretion of what else? Of potassium, technically in the urinary system, is technically an exocrine process, right? Usually it's a gland attached, so that's more of a protein channel. Either way, we are releasing insulin is one of our endocrine functions, right, of our pancreas. What's the other endocrine function of the pancreas? We got, well, that's the exocrine function, is digestion. But the other endocrine part of the pancreas, there's 3 cells, the pancreas, right? Alpha cells, beta cells, and what the hell is that? That's a delta gamma cells, right? So we got gamma cells, and those guys are releasing somatostatin, right? Octreotide, right? For our GI bleeds, right? So somatostatin. That guy it suppresses the whole GI tract, right? It basically constricts everything. It's going to stop a bleed from bleeding more than it should, right? It's going to stop everything, including the pancreas. So you get hyperglycemic, or you get a sugar elevation with somatostatin, right? But that's not its primary goal. It just kind of shuts down insulin. But we got glucagon, which unfortunately does not make your glucose go gone. It was not named properly, right? Glucagon does not get released when your glucose goes gone, but it gets released when your sugar is low. When your glucose is gone, then glucagon comes out. So it doesn't make any sense, right? But yeah, glucagon is going to raise your blood sugar, right? Whereas insulin was our only hormone that lowered our blood sugar. You only got one hormone that lowers blood sugar. You got 4 that were going to raise your blood sugar, and not including somatostatins. You got 4.5, right? So you got other hormones that are going to raise your sugar, and we'll talk about those in more detail. Okay, so we talked about environmental triggers that might cause our beta cells to be attacked, or our beta cells being the ones that are releasing our insulin, right? So diet can do it. Nitrosamines, so those guys, the people that like grilled foods and those little char marks and the conversion of cured meats and bacons to that sizzle, right? As long as and that's going to contribute also to development of type 1 diabetes. Okay, and certain stresses, Pancreatitis itself can do it, right? We remember chronic pancreatitis can lead to diabetes as a complication because we're destroying our beta cells. But especially those kids that have stressors at a young age, being hospitalized for a prolonged period of time puts them at risk for diabetes. So normal sugar physiology. So we said there is one sugar, one hormone that's going to lower your blood sugar. Should be here. All right, so there's only one hormone that lowers your sugar, brings your sugar back down to normal. All right, so insulin gets released in the pancreas, right? Where in the pancreas? Which cells? It was the beta cells, right? So our beta cells, our pancreas, release our insulin, and that's going to lower our sugar, right? So it's going to inhibit, right, glycogenolysis and lipolysis and proteolysis, right? And as we'll find out, those three processes are what raise your sugar, right? We break down our sugar storage, we break down our lipid storage, and our protein storage. That's going to raise your sugar. So insulin stops that, right? It actually files away everything. It files away proteins for later date, for in case you need to break them down later. It files away lipids. It reduces your triglycerides and your not so much your cholesterol indirectly, but it files away your fats into your adipose, right? So when you give insulin to patients, it's going to raise their fat content, or raise their adipose content, I should say. Okay, and then proteolysis, we're going to stop that from happening as well. Okay, but we have 4 other hormones, right? You got one, or let's do another different color. We got 1, 2, 3, 4 other hormones that are going to raise the sugar. These guys are going to start breaking down glycogen, our glucose stores. They're going to start breaking down lipids for our lipid stores, right? They're going to start breaking down proteins. Only one of them, and that is cortisol. And that's what actually gives all of our side effects for steroids, right? When steroids are given, we have side effects, and some of those side effects are usually related to our protein breakdown situation. They get easy bruising because the protein being broken down is collagen in our blood vessels, so they bruise easily. Their skin is paper thin because the collagen in our skin is holding together. If that collagen goes away, we get thin skin. They get osteoporosis, or they get bone breakdown because our bones are made of collagen, right? So, and what does insulin do? It keeps the sugar under 200. That's its one only job, is to lower the blood sugar, right? Keeps it under 200. Why under 200? What's the deal? Why do you even need it in the first place? Why not just let it ride? You intake a meal, sugar goes up to 600, and then eventually it should correct itself, right? So why even worry about that? Because you're gonna get starving eventually, right? And hopefully you'll eat. Why bring the sugar down? Because our white blood cells, right, need to function, and when your sugar is way too high, your white blood cells don't work, so then you're at risk for infection. Okay, so that's kind of the risk factor when you have like a stress response, or you have too much steroids on board, as in when you give steroids to a patient chronically, they're at risk for chronically high sugars, they're at risk for infections. So that's why we want to have a sugar that's under control, right? And in the hospital setting, ideally less than 180 is where we should be, right? So less than 180 is a good sugar, all right? 200 is usually the upper limit. That's why usually we have like sliding scale insulin. It says cover for greater than 180 or greater than 170 or greater than 150. It just depends who the lab director is at the time and what they decided on, or the pharmacy. They'll have a little meeting one day. It's like, let's make it 155. Come on, guys. Just make it, we're used to a certain flow, right? As long as under 200, that's kind of what we want, right? So we got one hormone to bring everything down, and we have other ones to raise it, right? So we got glucagon is involved in raising the blood sugar, right? So all these other hormones keep the sugar over 80. That's their one only job, is to keep the blood sugar elevated. At least they make sure that your sugar does not fall below 80, because what happens if it does, right? So if your sugar gets under 180, under 180, yes, but under 80, that's where you're going to start getting glucagon gets released, adrenaline, that's our SNS, right, firing off. Our SNS is firing off right here. When our sugar gets at 70, when we get a 57.6, I guess, that's where you get cortisol gets released, right? And then we have, we've got all our hormones kind of kicking in, trying to raise the sugar. Because what happens if you don't have sugar? Well, then your brain starts getting freaking out, right? You get neuroglycopenia, penia being a lack of, right? A lack of glucose in our brain, right? So when your brain doesn't get the glucose it needs, it can't keep things out of the cells it should, and then calcium and glutamate get involved, and you can can have seizures. You can start, things start shutting down. You get coma and seizure activity. When your sugar gets high, your white blood cells can't work, right? So you're at risk for infection. You're at risk for it. Do you actually die from a high sugar? You can if you don't get access to water. You get super dehydrated after a couple of days. But that's not going to kill you right now. What will kill you is a sugar that's under 70, under 60, under 50 or 40, right? So you can see over here on 30 to 40, that's where you start getting, irreversible neurological symptoms, right? And just a note over here, this neuroglycopenia has focal neurodeficits, right? So it's focal, so it mimics a stroke, right? That's why we always check sugars before we, start treating someone for a stroke, for that reason. Okay, so you can see why it's important to have 4 hormones at least, or 4.5 if we include somatostatin, to raise the sugar, right? We don't want to get the brain upset, and it's not just getting the brain upset, right? If you consider a seizure upset, it can lead to irreversible consequences, right? So glucagon, again, does not make the glucose go gone, but it gets released when the glucose is gone. All right, so it's going to do what? It does raises the blood sugar, right? That's its job from the pancreas, right? Is to raise blood sugar. And if someone has like chronic pancreatitis and glucagon is destroyed, well, we got 3 other options, right? Our pancreas, yes, that's where glucagon comes from. We're little alpha cells of our pancreas, but we have other options just to make sure our sugar is up and we can use it for cellular processes throughout the body. Okay, so what are the other hormones that do it? That'd be your cortisol. All right, we're going to spend some time with cortisol when we talk about steroids later in endocrine, but cortisol, that's released during stress, right? And that includes SNS activity, right? We got SNS response, you start getting cortisol get released, right? SNS will stimulate the to draw another line here, it's also going to stimulate ACTH. That's kind of its thing as well, right? It's going to, yes, SNS will do its own thing, release epinephrine and raise sugar, but let's finish the cortisol story, right? Cortisol gets released when you have an immune response or when you have a stressor of some sort, chronic stress, right? And your SNS also can stimulate it directly, and then you're going to get the release of endogenous glucocorticoids. So what the heck does that mean? So endogenous is what we secrete from our own self, right? Because there's such thing as exogenous, right? Exo being outside our body, right? So there's hormones we could give outside our body that we inject into patients, right? That'd be like our, methylprednisolone, we got dexamethasone IV push, hydrocortisone IV push. All these things we could give as a exogenous steroid, right? To raise does it give it to raise the sugar? Not really. Can it raise the sugar? Yeah, if they're hypoglycemic all the time, you could use these, but usually these are used for good reason, especially in the ICU, right? They're usually used for this inflammatory response, right? We're way too inflammatory in a sepsis process, or way too inflammatory in septic shock or SIRS, right? So we give exogenous glucocorticoids to settle down or simmer down now our immune system. Okay, so while they're on those steroids, you got to check sugars, because we know that they're probably, if they have a sepsis process, they might be at risk for infection. So we got to be paying attention when we're giving cortisol, exogenous cortisol-like substances, and they are called glucocorticoids for a good reason. All right, they're glucose raising, right? So they're going to raise the glucose. And why are they called corticoids? Well, they come from the adrenal cortex, right? So where's the adrenal cortex? It's a little sombrero that sits on top of your kidneys, right? So in our kidneys, we have, we are going to do all of our kidney things, and right on top of the kidneys are something that's added to it, right? Added to our renals is our adrenals, right? So we have our adrenal glands right on top of our kidneys, and these guys are it has different parts to it, right? There's the cortices, right? And there's one, two, 3 layers of our cortices, and then we have the nougat center, which is our medulla, right? And the medulla, that's what releases epi and norepi. So we'll get back to talk about epi and norepi shortly. But the 3 cortices are the corticosteroids. All 3 of these that get released are steroids, right? We got our glucocorticoids, we got our estrogens and testosterone. We don't care about it right now, right? But we also have our aldosterone. We're familiar with aldosterone, right? Aldosterone is our mineralocorticoid. And which minerals does it deal with? Only 2 minerals. Deals with Sodium, potassium, those are minerals, right? So sodium, potassium, that's why it's called mineralocorticoids. It comes from the cortices of the adrenal glands, and it deals with the minerals, sodium and potassium. That's its one and only job, is to get rid of potassium and also reabsorb sodium when the blood pressure is low. You get to restore preload and volume. All right, so we got aldosterone, and we have our glucocorticoids, back to our glucocorticoids, right? So these glucocorticoids are going to raise the blood sugar, and how do they raise the blood sugar? They're going to do all the things. They are going to stimulate two processes. They're going to stimulate glycogenolysis. So lysis is the breakdown of glycogen, and that's our glucose storage. So we're going to raise our sugar with that, and we're going to break down lipids, right? And that's going to eventually give us a lipid source, or a source that could raise our sugar. And we're going to break down proteins. As we explained, that's going to lead to a lot of complications if we have these around for a long time, because proteins are important in the body, right? So that's the story with our glucocorticoids, right? And we'll talk about ACTH and all these other things when we get over to the steroid chapter, when we talk about endocrine stuff with, disruption of cortisol, too much cortisol or too little cortisol, okay? So then epinephrine, norepinephrine. So these guys are stimulated, right when we have a sugar that starts plummeting, starts going down and down and down, then the SNS is going to fire off, and that's going to lead to a rise in sugar. And how does it do that? Well, it's going to cause a, stimulation of the glycogenolysis and lipolysis, right? It's going to break down your fat stores and your glycogen stores for quick energy. Okay, so it's immediate, and it's definitely going to raise our sugar pretty quickly, right? So whenever you have a stress response or an SNS response, that's going to raise your sugar. Okay, like when you run away from a bear, you want to have the sugar immediately available, right? And then growth hormone. So growth hormone is usually used in adolescence, right, to grow. And to grow, you need some sugars, right? But when you're an adult, it's just what kind of makes you hangry. It's what's going to be keeping your blood sugar elevated, right? It's going to make you reach out for some sandwiches or whatnot, right? It's going to be preventing hypoglycemia. And if you notice that cortisol is the only one that does proteolysis, and that's why we have all those side effects when we start giving exogenous cortisol. Okay, so the whole point of these guys is to keep the sugar within range, right? If it's less than 80, we got 4 reasons to raise the sugar. If it's greater than 180, greater than 200, that's when insulin is going to start taking effect, and it's going to start storing away things and prevent the breakdown of those storage pieces, prevent the breakdown of glycogen, prevent the breakdown of lipids, and prevent the breakdown of proteins. Okay, last piece is how does insulin work? Insulin is going to be bind to little receptors on our cells, right? And these little cells, these little GLUT receptors, they're going to activate a glucose transporter to come to the cell surface, and that's what's going to allow glucose to get into the cells themselves, right? So we need the insulin for that. If there's no insulin, your cells cannot obtain glucose. Glucose is a charged, huge molecule, so it's very difficult for glucose to get into cells. That's why we need this huge glucose transporter to be operational. Otherwise, we're going to have a rise in our sugars in the bloodstream.